just decided to start this here. All right, so we're going to transition to the clinical relationships. And there are some introductory ideas I want to talk about, and then I want to get some stories from you that we can use as we go forward. And so on the handout, I talk about some principles, and we're going to make our transition. Some principles. Is this working?
There you go.
Principles. Yeah.
Sounds like it's on.
Do I have to recite the declaration? Is it working? Can you hear me? Okay.
Turn up a little bit.
Yeah, maybe turn it up a little bit. Yeah, thank you. So some principles on the first page of your handout that I'd like to put out. It's really helpful in healthcare, clinical healthcare, to know who's responsible for what. So the first principle is being clear that patients are responsible for what they do about their health in their own lives. We are consultants to people. Okay? They take what they're going to take from us, but they are ultimately responsible. Clinicians, we're responsible for our advice and the choices we make, and I guess all together, but administrators in particular are responsible for policies. And one of the reasons I'm emphasizing particularly those first two is there are zones of autonomy, so patients get to choose whether they take the medicine that I think would be good for them, but they don't get to dictate the medicine I'm going to prescribe to them. And in a consumer culture, that breaks down. And as mentioned earlier, I've done consultation groups for primary care clinicians for many decades. And what I just said may sound obvious, but many clinicians get coerced, manipulated, guilted into doing things, prescribing things that they are not comfortable with in order to maintain the relationship. And then end up, the opioids was the biggest example of this, but it happens all the time. So what I'm going to be describing here is the skills involved in clinical relationships where there are trust issues around polarization, where there are good boundaries. That's another way to think about what I'm saying. The good boundaries are you're responsible. I can't dictate what you're going to believe or what you're going to do when you leave this office. I can dictate that you're going to wear a mask in the office if you choose to come, because that's the policy. But you don't control my actions. So it's obvious, but if part of what can happen with clinicians who get into sensitive, collaborative relationships with patients, you can lose your boundaries. You can lose your boundaries. You can end up trying to please a patient so that you maintain a relationship, and you end up being like a permissive parent. Okay, so in parenting, because part of a professional relationship, we talk about it's collaborative and so on, but the patient is the one that takes their clothes off. The patient is coming in because they have pain, they have suffering, and so we are in a bit of a hierarchical relationship, whether we like it or not. And so there is a parental aspect of this, and we know from 50 years of research on good parenting that love, nurturance, and limits are both essential. Confident nurturing and care, and confident limits. And at the end of our time here, I'll be talking about some skills that hardly ever get taught in clinical relationships, and that is how to deal with personal when the patient is attacking, when the patient is insulting. We don't, because I've taught these skills for you, I've taught other skills for you, we always teach about how to be empathic and so on. In this day and age, you have to have those skills, the collaborative, the joint problem solving, and you have to have some skills to setting boundaries when people are in your face. Okay, so we're gonna do some of both. Okay. And then the second principle is maintaining respect for patients, even if you see their ideas as wrong-headed or they treat you poorly. What's happened in the atmosphere of toxic polarization is disagreement has become disrespect. If you and I differ from each other, I no longer respect you. And what I've learned is that people will tolerate strong differences in whether you think Trump is the greatest president we've ever had or the worst president we've ever had, if they feel you respect them, as opposed to you disdain them. People tolerate strong differences if they feel respected. And then the last is, and this is of course part of the clinical world, is preserving the relationship and the possibility of future conversations. The old agree to disagree thing, to keep going. Advantage you have in healthcare, particularly in primary care, but anybody who has ongoing relationships with patients, is there'll be another opportunity. This is not a stranger here, and a particular conversation may have some turbulence related to lack of trust. But you keep the door open to continue the conversation. So those are some principles. And then on the second page, I found this distinction that a guy named Benson writes about when there's disagreement. And so what I've learned a lot about in Braver Angel's work is how to disagree better. In fact, the governor of Utah, Governor Cox, is now the head of the National Governors Association. And he's, I'm glad to say, a fan of Braver Angels. He came to spoke at our convention. And his initiative as the head of the National Governors Association is 2 words: disagree better. Disagree better. Which is the bottom rung, the essential bottom rung for dealing with issues of trust in this modern world. Disagree better, because part of it is if you disagree better, you're more likely to find some common ground. In fact, in Braver Angel's work, we use this phrase called achieving accurate disagreement. Most disagreement that occurs in the political sphere is I'm arguing against what I think is your view, not what your view actually is. We set up these strong arguments. So when you actually get to accurate disagreement, then we both know where we stand and why we stand for it. That almost always opens up some common ground, interestingly, as opposed to disagreement that is based on those stereotypes. So there's 3 levels of disagreement. Is it true? And that's the level of facts, information. Is it true? Factually accurate. And too much of what's happened in healthcare, when there's struggle between a clinician and a patient, stays at the level of is it true or not? Does this antibiotic treat the viral illness? No. Factual. But the other 2 are, is it meaningful? And that is, is it consistent with my values, my preferences, my group identity? And then, is it useful? Does it actually lead to anything? I'd say for people in primary care, that useful one, just as a comment there, is particularly helpful because a lot of times part of what a primary care clinician does is keeps people from having procedures or tests done that specialists might want to do that are not particularly useful. Is it going to change anything? You know, the classic thing is it going to change the treatment plan? Is an important and useful question. But staying with the first two, is it true versus meaningful? The meaningful can be about, so I'm coming in and nobody in my immediate circle believes in vaccines for COVID, and maybe people in my circle are not so sure about other vaccines as well. Or people in my world view masks as something that liberals do. In fact, the first time I did a workshop for legislators, COVID was still on, but vaccines were out. It was in the New Hampshire legislature, and there were 8 and 8. I walked into the room. The one group was sitting on one side of the room, all masked. The other group was sitting on the other side of the room, no masks. Did I need help to know which party it was? And it reminded me when we used to play basketball in the heat, you wear skins or shirts, right? But like tribal gear, it was really quite amazing. Now, by the end of the workshop, some people had taken their masks off. It was so interesting to see how they did it. But my point is that it's easy to miss in healthcare that something that we're disagreeing with the patient about, and they disagree with us, has to do with their group identity. I always like to say that people are referred to their clinician often by their family. They go home to their family. Their family knows they're going to see you. A lot of times they have to approve seeing you. And they want to know when you get home, what you said. And then that gets filtered through the family's values. I learned this as a child because my mother was the healthcare expert for the entire extended clan. She had a number of sisters, we all lived in the same neighborhood, and a dozen cousins. And then when kid would be taken to the doctor, the mother would check in with my mother, and I'd hear her on the phone. And she would say, what did the doctor say? What kind of pills prescribed? And my parents came of age when there was no penicillin and there was penicillin. And so penicillin was just the miracle drug. And my mother always wondered why the doctor did not prescribe penicillin at any particular time. And then they would have these conversations. And what I learned was that if my mother supported the doctor, they were good. If my mother didn't, there was a little, and that if my mother was not supportive, there were things like, so how old is this doctor? If they were old, kind of out of date. If they were young, not experienced. And so I saw early on that what we think goes on in our office, this is the drama being played out, well, there's this other drama out there. And now, in a whole culture of untrustworthiness, people's tribe can be on the internet. They can be on, a community where they form identity. I worked with this family really tragically. The mother and grandmother really got into QAnon in a very big way. And that became her community. That became her community. And any input she got from anybody, she would check out on that community. And so with that understanding in mind, I'm going to suggest that one of the skills in this day and age, when you have a disagreement with the patient, is to sensitively try to find out where they got the information and who they're connected to on it. Because those people may be more important than you or me in their lives. And then, of course, not to immediately attack that community. I've mentioned last night that the first time I heard the term political stress was when I was doing a workshop in Panama. This is back in the 1980s. All these military coups and other kinds of things. Well, we have it here now. And at the same workshop, I remember one of the family docs in Panama saying, how could you possibly take care of a child if you didn't know their grandmother? Well, we can't always know the grandmothers, but we need to know they're out there. Okay? And we need to know who the others are who are important to patients in their community, their healthcare community. Okay. So head and heart, and then the mistake, of course, makes if we engage people around their facts and your facts, and stay at that kind of conceptual level, and not about what's meaningful to them. There's something I learned in Greater Angels is don't start with facts that you disagree on, because there's something under facts, and that is about relationships and trust. I can't tell how many times I've given talks in which, and I can always tell it's Blue in the audience who says, how are you going to talk to people when they don't even accept basic facts? It's always Blue. Why do I say it's always Blue? Because Blues tend to go there. This is a big mistake in healthcare policy. Blues will come in, a presenter, with a PowerPoint and assume that the wealth of the data is going to mean everybody's going to change their mind. It's sort of anyway, I've just seen it over and over. Just as a red might say, if people are not really, they don't really love the country, how do you deal with them? Oh, welcome to Red World. Okay? So my answer is that facts, policy relevant facts, and I'm saying healthcare facts, as I said before, are based on who we trust. And so if you just start with, you say up, I say down, you say hot, I say cold, you say I say the vaccine works, you say it doesn't, we're just going to escalate. We have to get beneath that. We have to get beneath that. The other thing is about policy. We've learned from Greater Angels, so this is an aside, to not start with healthcare policy. Okay, should we have universal government subsidized healthcare? Good luck. Good luck starting there, because you immediately moved into the role of government, which is our big, long-standing debate in this country. If you start with a exercise I've been doing with a member of Congress from our district who wanted to have connections with his constituents that were different from his town halls. And so in different towns in his congressional district, they survey people on the list, they make an email list about what issues they are concerned about that they want to see members of Congress address. Healthcare is always way up there. And so we bring together 7 reds and 7 blues and the member of Congress, and then we begin with this question: what concerns do you have about healthcare, locally and nationally? And tie it to a story, personal story. What concerns you have, and then tell a story. And they do that, they pair up red and blue, and we go around the room. The member of Congress tells his own story. As I facilitate. When people finish that, you cannot tell who's a red and who's a blue. When they say things like, it's unfair, it's not right to live in a country where you have to quit your job, leave your business to work for a company because you can't afford your health care, or that a family is bankrupted. And they say, I don't know how to fix this exactly, but we have to fix this. And you can't tell who's red or blue. If we started with the role of the government in healthcare, it would be completely at odds with each other. So you have to get below it. And what you have in healthcare is a relationship that you can get below. So I just wanted to emphasize not getting caught up on, and I'll talk about some subtle ways you can use skills to get at that. Okay, so now what I'd like to do is to get some examples of situations that those of you who are clinicians have encountered with a patient that we could use as examples as we go through the skills. So on the ground, I'm going to have people in small groups do it first. So I'd like you to think about, if you're a clinician, and if you're not, you can think maybe about your own situation. But I'm mostly going to be looking here for clinical examples where you've been dealing with this this gap, this disagreement, this trust that connects to the political polarization. Okay, so I'd like to, some of the examples have come up before. I'd like you to think about an example that we might be able to use to talk about the skills. So everybody get the question? And for those of you who are not clinicians, you can think about your own experience with it. Okay? So come up with an example, and then we're going to have you share them in your groups, and then we'll pull out a couple we can use. Concrete example, very specific, where it would be helpful to process it in terms of using some skills. Okay, take a moment to reflect first. And again, the more specific you can be, and for an example, would be best. Okay, so when you get back to your tables, just have 5 or 6 minutes. Let the clinicians go first, because what I'm looking for is examples of somebody in a clinical relationship. Okay, go. If we went on all day, I'd never get you back from that. Okay, so looking for a case or two that we can walk through the skills with. And so happy to have nomination. Ideally, it would be a case where there was an ongoing relationship between you and the patient that maybe that previously had been doing okay. Ideally, we have some aspect of political polarization. That was, it fits the kind of broader theme we have here. So we'd like to offer one. Or you can nominate somebody at your table who you thought had a particularly interesting one. Or typical.
I'm going to nominate you.
Okay, there's been a nomination here.
All right. My patient was in his late 60s. He came down with COVID severe enough that he was hospitalized. And this is someone I've taken care of. He and his son, who has severe autism, so was with him, and his wife for many years. And in fact, my sister, when she lived here, bought unpasteurized milk from he and his family for a couple of years as well. So let's see where this is going. He required high levels of support, including remdesivir treatment during his hospital stay. And he came to me a couple months later, complaining of shortness of breath and weakness, and he couldn't do his chores on his farm because of those symptoms. So he requested ivermectin treatment for that, which I refused to provide, and suggested a prednisone burst to see if he had some improvement in lung function. Tried that a couple times without success. We came back again requesting ivermectin treatment, and I didn't go along with that. By that time, he had some arthritis pain, which was more severe than in previous times. So I capitulated and provided hydroxychloroquine for him to see if that could help with both issues. And that was also not effective, so he eventually went on to get ivermectin from another provider. So when he initially came in, though, his question was, did the remdesivir cause my shortness of breath and weakness? And so, not knowing this process, I did go through that with him. That was his concern, was it medication.
So don't go through the end up yet, just a pure case.
All right.
So where did it end up? Is he still your patient?
Yes, I saw his son for a wellness visit this month.
Did the ivermectin work?
Did the ivermectin work?
He thinks he's a little better, but
Hey.
questionable whether that's tincture of time. Possible.
He's got to ask.
Yeah. So what was difficult for you about this?
Just the difference in viewpoint, trying to explain this is the mechanism of what happened. The remdesivir is way out of your system. These are the potential side effects, but you should have had those in the hospital or soon after, and it's 2-3 months later. I don't think that's part of the issue, but his focus was on, is there a medicine that can make me better? Is there a medicine that hurt me?
Yeah, okay, thank you. Yeah, okay, thank you for that one. How about another one? I'll have a couple and then we'll go back and forth. Does anybody else have one?
Yours is faded. Your mic is faded.
Oh, okay. I'll use this now. Somebody else want to share that?
Oh, I have one.
Okay.
Nobody will.
Nobody will, sure, a citizen.
Well, look, there's one over there. Go over there.
Yeah, we need, this side of the room needs a little.
The red side or the blue side? Just asking.
Just asking.
Well, you're wearing blue.
He's got a great memory, though. Okay.
So I'm an OBGYN, so this is an obligatory labor and delivery story. If memory serves me right, anytime we admitted anyone to a unit during the pandemic, you have to have a COVID test, just to know if they were positive or negative. And we have the algorithm. If you're positive, face mask is way that way. Family members are allowed or not allowed to visit. But this lady was refusing to have the nasal swab. We all remember that pleasant back of their brain swab that we had. The reason she was refusing it, she claimed that that's how we clinicians were giving people COVID. That's how we were spreading it around.
Oh, wow.
So that was the very beginning of my relationship with this patient, in the sense that, she's getting admitted, man, you're in labor, you need to be admitted, here's a COVID swab, I want one. And she refused everything. And she left the hospital against medical advice.
And this was your first encounter?
She was one of our clinic patients, but it was my first encounter with her. It was one of my partner's patients, yes.
Okay. But she has seen your partner all the way through?
Correct. Throughout the
So
process.
Yeah, not somebody off the street. So how did it leave you feeling after this?
We try to feel empathy for people, and we try to understand. What I was sharing with the table is one of my best friends. His wife got divorced based on their stance on the vaccine. I think that marriage is a top-tier relationship when compared to patient-physician relationship. And it just opened my eyes that people were willing to compromise that relationship based on this.
Yeah.
So I try to understand the patient where she was coming from. Functionally can't compromise hospital policies.
Right.
That is situations.
Okay, thank you.
As you mentioned, patients are responsible for the decision.
If she can walk out the
the door. It's not a prison, not a prison yard. You got one?
I'm just thinking about, I'm a psychiatrist, and there's several instances where patients I've had relationships with over time. You get into the office and take their mask off. We've had a rule where everyone wears masks. So early on in the pandemic, I would notice that and say, it sounds like you're having a hard time wearing your mask or something, and put it back on. Sometimes I would ask them to put it back on. And then there are other times as it progressed, when I had my own COVID and I recovered from it, and I felt I had more immunity, and I just didn't make an issue with it. And they took it off. And so, how I felt. Partly I felt like I'm an enforcer, like I'm this wet blanket, and kind of the police state, you guys. So I'm now the you guys piece, and feeling there's a judgment. But there's also a sense of frustration and annoyance that they are not being respectful of me, and so there's frustration there. And I also feel a little frustration with the expectation of wearing masks, as we kind of the tail lasted a long time. So I kind of had my own little defiant acting out. I would wear my mask, but I would let them to do it, and so I think that they felt like they had me on their side against the big guy. So there's a
Whoa, boy. Yeah, have the psychiatrist take the microphone here. And just, it's not just, oh, we'll give you ivermectin anymore. So thank you. Okay, well, we have some material to work with here. And I'd like to now talk about skills, and then we can do some work with these cases. The overall strategy, and this is an application of very angel skills dealing with political difference to the clinical situation. The overall strategy, the kind of prime directive, we often call it in Braver Angels land, is connect first before you disagree, before you share a perspective. Disagree. Connect first. What often happens in arguments that relate to anything political is you say up, I say down, you say left, I say right, you say hot, I say cold, you say this is the fact, and I say no, that's wrong, this is the fact. And there's no connection. So the prime directive is always good to, sort of like the prime directive in medicine is first do no harm, right? We need some overarching things, As a therapist, the clinical relationship is the mechanism for all healing, and you have to prioritize that. We don't prescribe things that do healing outside the office. So it's like, keep that in mind. Okay, so connecting first. In the presence of a disagreement, the key is some version of beginning with, I hear you on that. Tell me more about that. It's just how to make it really simple, as opposed to, oh, that's wrong. It's connect first. And if you go back to this principle of showing respect, people feel if you have connected first with them, that you are treating them with respect. You're not going one up. And the thing about going, particularly if the ultimate outcome is in the patient's hands, that they're going to go along with what you want or not, if you go one up in the presence of a disagreement, you risk them feeling one down, and they're going to go one up on you. And so you're looking for this sort of, at the beginning, this horizontal connection that will allow you to use your expertise later. So that the prime directive is connect first, then share your perspective. And then I say in personal ways, where we'll talk about using I statements instead of truth statements. To say, this is what I've looked at, this is my understanding of such and such, this is I've looked at your profile. Using personal terms as opposed to truth statements. Okay? Connect with the other person, and when you express something, use the first, the preposition I, instead of the data, the facts. this is a clinical relationship, and you're apt to have turbulence here. And the patient is apt to already have some beliefs about this before they encounter you. So you want to avoid getting into an argument right from the beginning. Okay, so what are some steps in this? And the first is, and by the way, these skills are widely used. Braver Angels and I didn't invent these skills, but we're applying them to the presence of disagreement around medical situations. So the first one is the classic knowledge or paraphrase back what the person's saying. And the thing I'm adding here in a clinical relationship is focus on their concerns, not on their beliefs. So you're concerned that the vaccine may harm you, as opposed to you think that the vaccine causes harm. You get the difference? They're here to see me as my patient. We're not debating. Braver Angels, we have a debate format too. That's different. Just be objective. Be objective on it, okay? But if it's a patient seeing me, they are not bringing this up as just a point of public discussion. They're bringing it up because they have a concern. So go to feelings, concerns in your acknowledgement. You're troubled by, you're worried by such and such. Is that making sense? I mean, it's subtle. It's subtle, but it gets below the level of factual differences because they're only bringing it up because they have feelings about it. I'm starting with their feelings. Is that making sense to everybody? Okay. So, example is, so you're concerned that the antiviral they gave you actually has made you sicker. You're worried about that. You're worried about that your symptoms now are back there. If you were dealing with somebody who, like with masks, some people think, the masks are doing harm to them. Okay? So you're worried that you're going to wear the mask and it's going to cause you, it's going to make you sicker. Even though I think that's the last thing in the world, that is the factual case. This patient is there. So I want to go back to yours, because I'm trying to keep three of them in my head at the same time. And it was, she wouldn't do the swab. Was there something else she wouldn't do, or was that the main?
Oh, face masks.
Face mask, I'm sorry, with face mask and swab. And of course, yours is trickier because you didn't have a relationship with her. But sometimes that happens. I mean, it's so much harder. It'd be interesting if one of your partners who had taken care of her was there, how it might have gone down. And all of these skills are harder outside of a relationship. But the opening with this is scaring you. I mean, I'd be looking for a feeling word. What I'm getting is that this is scaring you to wear this, or this feels like a big imposition to you, or that we're controlling you. In other words, they try to get at, and maybe she was already too far gone, but it wouldn't be, I would try to get at a feeling that if somebody, boy, she's coming in labor, oh my goodness, what a vulnerable place, okay? And so I'm trying to imagine, and some of what I do with this is, the first time out when I encounter this kind of thing, I just do my best, and then I think about it a lot. And then the next time, I try to think about what I'm doing here. This woman's coming in labor, and she's already scared, and she thinks that the swab is going to do something to her brain and the mask to her, So is there some way I could try to get at, this is really throwing you now, maybe even like throwing you some way in. You came in here to have your baby, and we're asking all this stuff of you, and it's just throwing you for a loop. I don't know if I can pull it off, but that's what ideally what I want to. And it may not work because she may be too activated, but some way, do you follow what I'm saying? Some way to access an emotion, a concern underneath oppositionality. Because the thing is, they don't have to be seeing you. They don't have to be seeing you. They're there voluntarily. They come in for help. I work with police officers as well. People don't, a lot of times they're dealing with people who do not want to be around them. Okay? But with you, they've chosen to be with you. So there's something in there you might be able to access about acknowledging, trying to get at. And that's the second one, that seek to understand. So it might be, so can you tell me, and the thing is to be, the seek to understand is, you have to really want to understand where somebody's coming from. You have to actually be curious. We have a very courageous colleague, Monica Guzman, who's written a great book called I Never Thought of It That Way. I never thought of it that way. It's about curiosity. And so can I access my curiosity about where the patient's coming from? At the break, I mentioned to somebody that a strategy I use more globally after 6 years of doing this Breaker Angels work is I try to imagine I'm an anthropologist studying another culture. Or I'm a historian looking back at how the plague was handled in the Middle Ages. And wasn't it interesting that this group rose up in this group and they beheaded people over this? And where did that come from in terms of the culture of the time and the politics of the time? So I get out of the fact that I have a stake in this now. I mean, I have my views. Okay, so trying to get myself out of it to look at the red blue divisions from an outsider's point of view, like an extraterrestrial coming down and saying, look at contemporary United States. They can't even handle a virus without getting. Isn't that? I wonder how that happened and what's going on from an outsider's point of view, as opposed to somebody who either voted for Trump or didn't. Okay, voted for Hillary, Biden, or Trump, because then you're internal to it. Anyway, so the point is the same thing with patients is to try to have an attitude of curiosity. And so the key part of this, and these are just sample lines of communication, and any of these can backfire if you don't have the right nonverbals. But I'm interested to know how you came to see it this way. What leads you to believe that the antiviral is what's causing this? There would be some connection, and maybe for this guy, maybe that was the big medical intervention. Other than the stabilization or whatever they did in the hospital, this was an active intervention where he took this medicine, and maybe there's somebody else. So what sources of information? What do people you trust? Again, these are phrased, as I'm reading this out, sounds a little stilted. You have to put it in your own terms. What do people in your family say about this? What's your wife say? I know your son recovered from this. Some way to try to get at how they came to believe what they came. Do you know people who have been hurt by the vaccine? Get people to tell you a story. That's what I'm saying. Get them to tell a story. At a big macro level, it's all about story. We have certain stories that relate to science and medicine, certain forms of communication, and we tell ourselves, and the patient has a story behind what I might see as their inaccurate medical view. And the key is, when they tell you, well, I got it off the internet, that's, at that moment, what should you not say? What should you not say when they say, I read it on the web?
Oh, Dr. Who.
Dr. Who, yeah, that's right. Do not put it down immediately. Do not say, do you see that diploma, that license on the wall? In fact, if you ask a question of curiosity, so tell me how you came to see it this way. When they finish, you just have to acknowledge what they said, appreciate them telling you that, do not nail them. Because you have just, well, why not? Okay, well, why should you not when they say, I got it here, the internet, plus my brother-in-law, and I'm suggesting you just say, okay, we're going to move on to something else in the conversation. But I'm just acknowledging that they answered my question. What's the downside of then undermining their sources? What's the downside of then directly proceeding to undermine the sources?
You just tried to create trust, and now you're undermining your
Yes,
trust.
you just tried to create trust. So, yes, so tell me how you came to see that. No. Stupid. All right, and then the rest of the conversation, you lost it. But I'm saying it's hard not to. It's hard not to say, well, they got it on the internet. You know, there's a lot of misinformation out there. They know that, but they thought this was actually good information. That's why they're bringing it up. And so even I'm trying to be a nice guy and make a big generalization about misinformation, you know, the internet's the World Wide Web and blah, blah, blah. So I'm doing it nicely, but basically I'm saying, nah. Okay? And so just, if you ask a question of curiosity, how did you come to believe the world is flat? Okay, and there's a Flat Earth Society, by the way. I always keep that in mind. When I think about these things, there's members of the Flat Earth Society. They have their models. Okay, Flat Earth Society, so you've been part of that for several years. Then we move on. As opposed to, really? Okay. So the next thing is to agree with something if possible. Agreeing with something with somebody before you disagree. See, you're going to end up disagreeing with them. That's where we're going. Okay? To agree with something, yeah, these swabs can be really, what you call it, a brain swab or something? They're terrible. I just did one recently. You know, they're terrible. You know, I hate these myself. It's really, or, you know, masks are just obnoxious, you know. And something that we agree in Braver Angels world, we're always looking for that kind of thing. So we're arguing about police reform. I'll get to this. Arguing about police reform. I think what we both want, we all want, is safe communities. And police are part of that, and they ought to be doing their job. Something there. Something we agree with. Yes?
I'm just wondering if the agreement is the safety of the baby. I think she was afraid she would get COVID.
Okay.
And so perhaps that's a commonality.
Beautiful. Beautiful. We both want you to have a safe baby and be both home happy and healthy. Yeah. Something, and in healthcare, there's always something. It's welfare. We want something. We both want something that I can do for you that helps you. Okay? Like it's something basic. Finding something. What's the advantage of finding something to agree with before you disagree? What's the advantage? You're connecting. You have common ground. If you agree with me on something, I think you're not so stupid. Right? I mean, you're obviously a smart person if you have something to agree with me. And you're also treating me with respect. That is something I've learned over and over. In fact, in some political conversations where somebody is really on a roll, we have a workshop called Families in Politics where we teach people the skills to engage with the family gladiator. The person who is there to straighten everybody out. Everybody has one. I see smiles and you're thinking of them now. With those folks, we actually don't start out with acknowledge because they just ramble on. But start out with, I agree with you about such and such. Completely disarms them. Because they're used to nothing but opposition. So starting out with something you agree with. So, and some of these are pretty easy, like vaccines can have side effects. Medical advice has been changing. So,
this, Alan, your thing, you're talking about how and you can even add it's frustrating because there used to be no masks and now masks, and I get it that sometimes I've been wearing a mask, and then you have these policies. So agreeing with something. What was I here? And admitting, and this is the power of what Francis Collins is doing, acknowledging mistakes at the public policy level. And I have to say that some of what we're dealing with on the ground for patients is mistakes made at the higher levels. Particularly communication mistakes that contributed to the losing of trust. Okay, so admitting the lack of full knowledge, admitting all the things that I know how to do is an important step. And then, now we're at the point where you share your perspective. And what I'm really saying is, in terms of these skills, you do some dancing around, a dance of joining and connecting. The way I see it is, the patient has some momentum. They're like this train that's taken off. You have to get on the train before you have an opportunity to suggest steering it in a different direction. To take that rail as opposed to this direction. If you don't get on the train, you're usually talking into the wind. In fact, in the Brave Angels workshops where we talk about political differences, we often use a skill that is this one here under perspective. If I were to call out this next bullet, it would be a pivot skill. Sometimes it can be helpful when you've listened for a while, you've acknowledged, to before you go on to disagree, to say something like, so I'm going to offer my perspective on this. Okay, the patient sometimes, I was talking to a doctor recently, the patient went on, I gave her a lecture. Like, she'd seen this guy for 25 years. He'd been with his wife. He gave her a lecture about vaccines and about big pharma and blah, blah, blah. And so, so she listened for a while, and but what would have been helpful at that point, I have some thoughts about that. Would you like to hear them? That can sound weird when somebody has come into your office expecting to get your input. But what's the event? I'm not saying that's a universal one, but if you feel like you're not sure the patient is at the point to hear you because they're on a roll, even though you've acknowledged, what I never want to do is share my views on something to somebody whose all the signals they're giving me is I'm not interested. I'm wasting my breath, and I'm just going to further the argument. And so if somebody, a lot of it is emotional, it's just, okay? It's not personal. It's just, and I've done my best to get on the train. And so there is, when I do the perspective, there's a skill called a pivot. I think it's the only communication skill I ever created. Okay, so the rest of it. Pivot is getting, okay, I have some thoughts about that. Can I share those now? Notice, can I have the floor rather than seizing the floor? People almost always say yes. Almost always say yes. If they were to say no, well, you got other issues here. But they'll say yes, and then take a breath, and then share your perspective. Again, that's not a universal one. But when you get to the perspective where you're going to have a different viewpoint, you want to have some calmness between you and the patient so that they might be receptive. If you don't feel there's that calmness, acknowledge and listen to them again, ask them to say more feelings, agree on something, and then pivot to your perspective. So, the key to perspective sharing in a disagreement is I statements rather than truth statements. Now, this is where this is my understanding of what the best
practices with this. So this is my understanding of that. I've looked up the side effects of this particular medicine, and this is my view about the unlikelihood well, the way you said it is, it was going to have the side effects, every medicine has side effects, my understanding of this from looking at this is that it would have shown up. And so my judgment on this, although I understand for you, now here's what I'm going to do. Understand for you, I'm just going back to you. Understand for you, you took that medicine, it's pretty potent, and then that's the most potent drug you took before you got these symptoms. And so I understand that for you, it looks like, hey, maybe that's it. And then I might say, I'm not saying it's impossible. However, this is what I understand. I've used this on patients, and it would be the first of this guy. Okay? Now, you see what I'm doing? I'm using I all the time. I just went back to your concern. The big thing in sharing a perspective where you're going to disagree, you're going to share some fact, is to try to fold the patient's concern into your sharing. When I granted him some sense in ability that he had this medicine, later on he got these symptoms, and he made the connection. Okay? I remember once having a family conference with a family who, in their own belief, their mom's cancer was maybe connected to the gallbladder surgery she had 3 months before. But she had this big medical event, and then maybe it spread the cancer. And they were having trust issues with the medical people around us. We got everybody together, and they came out with the story. Like, oh, okay. The surgery had maybe caused this. Oh, and then nobody was paying attention. And so you say, okay, I see, that was a big event. And surgery can, cause lots of disturbances in the body. And so I see how you came to think that was the case. So I'd like to share my view about that. Okay? But I just credited them, honored them. Okay? And what we know in human relationships is that people will now listen to you. So you try to fold into your perspective what their own narrative is. You always affirm the patient's autonomy before offering counter advice. It's going to be up to you to decide whether you're going to take the vaccine or not. And that my view is, as your doctor, I think, is concerned about your health, that is going to be best for you. And you might even want to fold it. I don't give a rip about pharma on this. I don't give a rip about blah, blah, blah. I care about you, and I'm concerned for you with your risk factors. So that's my input for you. And of course, it's up to you to decide. So the firmer you are with something that the patient has to do on their own, the more you acknowledge that they're going to make the choice. Okay? But the hard part is they don't make your choice. They don't make you give ivermectin. And that's where you have to come down to your express personal concern with the patient and about how you practice medicine and what you are not comfortable doing. Based on my job is to do what I think is best for you. Your job is to decide what you're going to do with my input. And I cannot prescribe you that medicine in good conscience because I don't think it's going to help you and it could hurt you. You notice I'm doing that with firmness but a hint of sadness. I can't go along. But I'm doing it with the I statements. With the emergency situation you had with this woman in labor, a lot of it is people feeling out of control, losing their autonomy. I just stick things up. So part of what I try, always when somebody's really reacting, is keep emphasizing, it's up to you whether you want to be here now with these procedures that are driving you crazy. And you can decide to stay here and do this, you can decide to leave. Just people, when they get really reactive, are afraid their autonomy is being taken. But they can always say, you're not police officers. The police officer at work, but they can put you under arrest. You're not putting people under arrest. They can always leave. So, and then the last things I'll talk about here are closure, asking where the patient is in terms of your input. So this is the processing. This often gets lost in a disagreement that doesn't resolve between the clinician and the patient. And so the patient would like ivermectin, you're not going to do it. And what I recommend is before you finish saying, so where are we now? So you're hoping I would prescribe the ivermectin. I've said I'm not, and that is for no reasons. And so where are we now? This is the closure part. It sounds like we haven't connected. We've connected on this level, blah, 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 these parts of your care. It sounds like we're not connecting around whether you want to do the drug. So we're basically, what next? Okay, where do we go from here? And if there's still disagreement, trying to, just like you try to agree, try to appreciate the patient's honesty. But this is something I've learned as a therapist. If somebody challenges me straight out, like, hey, I don't think you're paying any attention to me about this ivermectin. I think you're blowing me off. Thank you for telling me that. I'm glad you're honest with me. And so we come to the end, we don't agree. If somebody has been straight with me, it takes courage. I'll acknowledge that. And then I will ask if we can continue the conversation. Okay, so again, if you have an ongoing relationship, we have this little turbulence here, we can talk again about it if you like. Okay. I'm signaling to the patient, I'm okay with you. We didn't agree here. You're not following what I hope. I'm okay with you. We had this disagreement. We can what? So a little processing at the end. Now the last set of skills, I'm just going to go through these quickly, and then we're going to finish up. These are new ones I wrote up for this workshop, by the way. Skills for handling verbal attacks. And there's some principles. So here I'm talking about when the patient's telling you not only is Big Pharma behind this vaccine, but I wonder if you're basically the same, wonder if you're on the take. That's what I mean by personal. So the principles for handling verbal attacks, and we teach some version of these to elected officials because they get attacked all the time. Don't either be a victim or a counterattacker. Don't let somebody sit there for 15 minutes and attack your integrity. Okay, that's being the victim. But don't tell them they're just a bunch of QAnon dupes. Okay, so you don't attack back. Don't stoop to defending your character or integrity. Never say, I'm not on the take from Big Pharma. Don't say, I don't lie to patients. Can you see, if you're doing that, that's Richard Nixon, his famous line is, I'm not a crook. You don't get on TV and say, I'm not a crook. And so you don't defend your integrity. I learned that from my daughter. Never defend your integrity to somebody who's attacking it. You just stooped. You just stooped to that level. Okay? So that's a principle. Stay calm and firm, and give the patient the opportunity to soften and reboot the conversation. Because sometimes people come to us in a distress, and sometimes and we certainly deal with that in the psychotherapy world. People come to us because they have relationship problems, and sometimes they don't express themselves very well. Okay, and so they ventilate, and then you have to manage that, and then they say, "I'm sorry, I didn't follow up." Okay, so some scenarios here, and assumes you have a clinical relationship. The indirect attack. Doctors these days are just doing the bidding of. Now, here's my suggestion for a response: to firmly ask for clarification. Joe, are you saying that I'm looking out for myself on this and not you? And that would be somebody in this, maybe it's just the Midwest, passive aggressive. All these doctors nowadays are just, blah, 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 and they're all taking so, So Ellen, are you saying that about me? Don't let that passive aggressive thing from healthcare. Is this about us? Okay. And then usually in Minnesota they say, no, I know you're not. But I'm basically saying don't do that stuff here. Don't go on about all these doctors. I'm your doctor. That's really what I'm saying. So let's be real. And then often the patient may apologize, and then you move on. But again, don't give a speech at that point. And then a direct attack, less common, but you have to be ready for. You're lying, you're in bed with, you're only saying this because. And again, if this is an ongoing relationship, these are just some ways you can think about. The first one would be, whoa, that's a really strong thing you just said. Do you believe that? Or are you just upset? And they may have a chance to backward attack. If they reaffirm the attack, then you can raise the question about whether to continue the conversation. I don't know where that leaves us right now. I see myself as trying to be helpful to you, and you see me differently. The patient apologizes, you can acknowledge that they're under a lot of stress, and go on with the conversation. If they dig in or escalate, and again, these are for extreme situations, but part of what I've learned, and we teach this at Brave Angels workshops, we always have skills for difficult moments. Because if you can't exit a very difficult conversation, you're going to be reluctant to have it. If you can't get out of the conversation with the family gladiator, with your dignity intact, you're probably just going to shut down. Okay, so this may be only once in your career you have to use it, but it's helpful to know what you would do. And so in this case, they dig in or escalate, you have to exit the visit. You have to exit if they're digging in without defending yourself or criticizing the patient. Here's some words. I think we should stop now. You'll have to decide at some point whether to continue with me as your doctor, and then we would have to have another conversation. And the patient will probably say something else, and you let them say that, and then you just say, let's stop at this point, and then leave the room. In all the years of consultations with primary care clinicians, there have only been a few times when they had to do this, but it's helpful to know when to get out of Dodge. This is no longer constructive, but you notice what I'm saying, this isn't constructive anymore. I'm not saying you are attacking me. You are this, you are that. This isn't working. You can finish now. If you'd like to continue this in the future, we're gonna need to talk about what just happened, and then exit. So what I'm saying is, going into very difficult, we learned this at Brave Angels, very difficult conversations, you have to have an exit strategy that doesn't disrespect the patient, but also respects you. I'm not going to beat up on you, but I'm not going to be beat up. And I'm going to leave the door open for another conversation, and this is one of the things I've always consulted on. If the patient is on your schedule again, don't walk in the door and say, how can I help you today? Walk in the door and say, okay, you're back. Let's talk about what happened. Does that make sense? Because otherwise you just signal you can pull that stuff again, as opposed to, so we need to process. Okay, so what I'd like to do is to have my Brave Angels colleague, Rob, come up and say a few words about Brave Angels, and then we'll finish up. Oh, both of you, that's right. Sorry about that.
Yeah, I'm the data guy, and Damien's the do you love your country guy. And we both find out that he likes data, and I love my country too. So we have an Idaho Braver Angels state alliance. We have a Treasure Valley alliance, and we have a newly forming Pocatello alliance. But you go to workshops like this, and your brain is pretty full. And as Bill was talking about, you practice these and you get a little better. And one of the things that we do in Idaho is we have a monthly Zoom call, the second Wednesday of each month at 7 o'clock Mountain Time. And the purpose of that call is, one, is just to create community of Brave Angels people in Idaho, and also create the opportunity to practice the skills and things that you learned in various workshops you've taken, like today, or online. If you want to join that call, there's a piece of paper that's taped on that back. And there's a QR code, and you just point your camera at that, click on that, and you register for the meeting. And then we also have 2 handouts in the back, and both Damien's and my email addresses are at the bottom. So I don't know if Damien has stuff all here.
I'll say one thing.
So everyone got the information they needed. They want to continue, and that's great. But one thing I want to say is thank you all for taking the time. This is a long process. I know a 4-hour workshop is taking a lot of your guys' time to continue to develop, to continue to be better servants in our community. I know I appreciate it. I know the community appreciates seeing continuous action. And even in, like, I have some friends that are a little distrustful of the medical community, some family. But seeing effort goes a long way. And it shows that you want to help us. And I appreciate seeing that. Thank you all.
Thank you. All right.
A little applause for them. Thank you for saying that your community or some folks who will provide some opportunity to practice these skills. And so what I'd like to do as we finish up is to ask you to take a moment to reflect on something you're taking with you from our workshop today. Some take home, something that you found that will be useful in your work. So take a few seconds to do that, and then we'll hear from some folks. Okay, so a few folks, do we have a second of these? Oh, we do, yeah. So just a few of you would say something you're taking with you from our
No, thank you. This is really excellent material, and I think it gives me personally a platform to continue developing interpersonal relationship skills, not only with my patients, but with my colleagues and superiors and other people. I just wanted to mention that.
Thank you.
Yes, thank you. One thing I think I'm taking with me, maybe practically or a little more tangibly, is around the I statements with data. I think I've tried several of these skills, maybe not as cohesively as you've outlined them, but I think that often we're taught to lead with data, and that's kind of trained into us to some degree. And so, like if I have patients say something like, I hope I survive this, and I don't know if they're going to, I can easily say, I hope you do too, right? Like that's natural, but I'm not saying, my review of this, I'm concerned or whatever. I can say the data shows that the COVID vaccine is 90% effective or whatever, and so maybe in some of those areas thinking about making that shift is a response.
Thank you. Yeah. Others?
I like the verbal defense. Whoa, you say that about me? Where are we here? I like the verbal defense skills. Or a colleague, one time called me up.
A little closer to your mouth.
He was yelling at me about something. And the first time I remember this, I said, because Daniel said, I'm going to hang up now. And when you get better and have better behaviors, you can call me back. And he called me back. He started yelling again. And I told him again, his name. I'm going to hang up now. When you have better behaviors, we can have this conversation. Finally, the third time he called me, he apologized. And he said, I'd like to have this conversation. Can you have it now? I said, no, you can set it tomorrow morning. But it was great, what you just said, triggered, somehow I stumbled into that. And it's a great idea to have those things in the back of your head. So thanks.
Yeah, even if you rarely have to use them.
just a couple of things I'm taking away. I work with new nurses a lot who really work on assertiveness and communication skills. So some of these responses are spot on for the experiences that they're having. And I'm excited to share it with them. Also, as a mother of teenagers, this is gold.
Thank you. I'll tell them. It reminds me of a story that we did a bus tour with Burger Angels. We rented a politician's bus. It was Representative John Boehner's old bus. He was the Speaker of the House with his bus driver, and Nick, who was very skeptical about what we were doing. But we went through a number of towns and we did workshops. And I remember we pulled into a small town in Vermont and we had our Whole America Together sign on the bus. And a guy came up and he said, "Oh, what's this about?" And we chatted, and he said, "Yeah, can I come to the workshop?" "Yeah, so sure, come to the workshop." And at the end, when I asked what people were taking with them, it was about political disagreement. He said, "Yeah, I can use this stuff with my girlfriend." And that was one of the highest compliments I ever got. So I want to end by once again saying how bold and innovative it is for you all to do a workshop on this topic. This, you know, this is happening all over America with healthcare professionals. And it is part of wellness, it is part of vitality. And so the fact that you wanted to do this and give us the opportunity to come and kind of help to develop this workshop, it really means a lot. We have a vigorous group in Idaho of Burger Angels, and we're going to be doing more in the future. I'm doing my first workshop for media people on Tuesday, another profession that has lost a lot of trust, and I really appreciate, and I hope they do as good a job as you did, doing the humility part of this. So what's happened internally? How have we screwed up? How have we been, how have we contributed? What's on our end, as well as one of the larger forces, because that's the way we build trust, is to have some acknowledgement that we co-created this environment of lack of trust in this country, and we have to build relationships to get out of it. So I have enjoyed this very much, and then Molly, shall I hand it over to you for?
No, you have to
Yes, we're going to debate this. So you just tell me, Molly, that I did it's not a new script. Just say, "No, you did great," and then you can say goodbye to everybody.
Well, you did a great job.
Yeah, so sincerity. That's sincerity.
Okay.
Don't be smooth.
Thank you, Dr. Doherty. Thank you, River Angels. Thank you to our sponsors and to St. Alex, who are very gracious to host us today. Thank you all for coming. We will be sending an evaluation by email to you for both today and for last night. We really appreciate that feedback, both for the CME purposes, but also because you're developing this workshop. And so be thinking about if we were to do this workshop again for your colleagues, what hit should he know so that it's even better in another state when you do that? Is that fair?
Sure.
Good. So we'll pass that on to you. So thank you once again, Dr. Doherty, for coming. Maybe we'll get you back out here to Idaho.
Okay.